Hi, my name's Dr. Chris Owens. I'm the owner and founder of Advanced Laser Training, and I appreciate you being here with me today. We're going to learn about soft tissue laser dentistry and its advantages in a typical dental office or specialty office. I'd like to thank our sponsors, DenMat, for making this course available, this webinar available. Now, why lasers? Why now? Why me? One of the things we're seeing in laser dentistry is lasers were first introduced into dentistry in about 1978. And in the last 35 years, we have gained about a 17% penetration rate into dental offices. In other words, about 17% of dental offices own a laser of any kind at this point in time. Now, that penetration rate is predicted to more than triple within the next 3 to 5 years. So what's taken 35 years to accomplish is expected to be tripled in the next 3 to 5 years. So we're seeing an amazing explosion of soft tissue laser dentistry being adopted by dental offices across the country and really across the world. Now that's brought along by two basic things, and that is diode soft tissue lasers have become much less expensive over time, much smaller over time, and their efficacy or usefulness in a general dental office or specialty office has been increased. There are far more things we can do with a laser than we used to be able to do with a laser. So, basically, the way it works out is today about 95% of the clinicians that buy a soft tissue laser will buy a diode laser versus CO2 lasers or ND YAG lasers. And that's because the diodes are the least expensive, smallest units available for soft tissue laser dentistry. And we are seeing many offices use them in place or instead of electrosurgical units, because they can do the same things electrosurgical units can do in cutting tissues, coagulating blood vessels, cauterizing nerve endings to limit histamine release, which leads to post-op inflammation and pain, and sterilization of the wound edges. So they can do everything an electrosurge can do, but they also can do other things like herpetic lesion treatment, athus ulcer treatment, decontamination of sulcuses around pockets or within teeth for our cleaning appointments, and also periodontal applications. So that's why we're seeing them taking over. The word laser, we're getting into some basic laser physics, and trust me, I'll keep this as short as possible, but I want you to have a little bit of a foundation about what we're doing and how it's done. Now, the word laser stands for light amplification by stimulated emission of radiation. So we all know that lasers are devices that use light in order to do work. Well, how can you make light do work? Well, it's better be very strong light. So how do you intensify or strengthen light? Well, you do that by taking light and amplifying it. Now, how can you amplify light? By stimulating its emission of radiation. Albert Einstein had a theory that lasers would be possible. In other words, he theorized that there would be certain materials within our physical world that when we pumped energy into them, be it electrical or photonic or light energy, those materials would emit radiation of a specific wavelength. And he called those materials active mediums. And every laser on the planet today is named after its active medium. My laser pointer here is a helium and neon laser pointer. The active medium for this laser is helium and neon in a little bubble. We're pumping energy into it from the battery, and we're making it emit radiation that in this case is 632 nanometers in wavelength and puts it in the red portion of the spectrum, which is why this laser pointer is red in color. Now that we know what the word laser stands for, let's go to 3 properties all lasers share. Now, sometimes there is some misinformation as to what a laser is or is not. A true laser has 3 properties that it shares with all other lasers. And that is, each laser on the planet has monochromatic, in other words, is monochromatic, which means all lasers are a precise or specific wavelength. So you'll never buy a laser that it says we're 100 nanometers in wavelength to 2,000 nanometers in wavelength, and all you have to do to change the wavelength of this machine, thus its targets, is turn a little knob. Because what you have to know is that every active medium on the planet has a precise and specific wavelength associated with it. So in order to have a laser with 1900 different wavelengths inside it, you would have to have 1900 different active mediums, which means you would have 1900 different lasers in that little box. So again, lasers are monochromatic, precise, specific wavelength. Secondly, lasers are what we call collimated. They do not spread out from their source, which is why my little laser pointer here stays a tiny dot, whether I point it here at this screen or whether I go all the way to the back of the room and point it at the screen. It'll still be a very small, tiny dot. Where typical lights that are polychromatic, multi-wavelength will spread out from their source and bathe the room in their energy, lasers stay collimated. The third and final property of all lasers is that they are coherent, which means the light waves that a laser puts out, and of course remember all energy travels in waves, the light waves a laser puts out are superimposed on all of the other light waves that it puts out. And so another word for coherent is in phase or in synchronicity. So all the peaks are on top of all the other peaks and all the valleys are on top of all the other valleys. So if you get a test question and it says, what are 3 properties all lasers share? Try to remember MCC. So that's the acronym I use to recall this, just like we used acronyms all the way through our hygiene or dental or specialty schools for all of our testing we had done there. One way that you can help remember this is think of a group of army men walking down the road and they're all wearing green, so they're monochromatic. They're all staying within the road and walking in a row, so they are collimated. And they're all going left, right, left together, so they are coherent. So maybe that will help you remember the answer to 3 properties all lasers share. Now, one thing we talk a lot about with laser dentistry is the wavelength of a laser. It is the wavelength of any particular laser that gives it its specific properties. And the specific properties of the laser let us know what it will be good for. Now, wavelength is the measurement from crest to crest of a light wave. So when we talk about your wavelength of your laser, you'll want to be sure you know what it is, and you'll know that that's what determines what targets it seeks in the physical world. Now again, wavelength measurement from crest to crest, and we measure wavelength in a unit of measurement called a nanometer. Now, what is a nanometer? A nanometer is 10 to the negative 9th of a meter. 10 to the negative 9th of a meter. So, if I go 10 times 10 times 10 times 10 times 10, 9 times, that little piece of a meter is a nanometer. So a nanometer is actually 1/1000th of a meter. 1/1000th of a meter. Now, I also wanted to point out on that last slide that light waves are actually, they look like a slinky, not that sine wave. You'll recall that when I back up one more, you'll recall that this looks like a sine wave. And a sine wave is a 2-dimensional representation of a 3-dimensional object. And that 3-dimensional object is a light wave. Light waves in reality look like a slinky spring. They're a circular phenomenon, and wavelength is the distance from the top of one slinky ring to the distance of the top of the next slinky ring. Okay? Now, the other thing that's very important that you know about your laser is what is it highly absorbed by? Because the way we figure out what a laser can do for us clinically is we figure out what targets in the physical world highly absorb that laser's energy. Now, diode lasers, which all of us are using, highly seek melanin and hemoglobin, as you can see on my slide here. Now, melanin is pigmentation within our skin. The darker complected that we are, the more melanin we have within our tissues. And then hemoglobin is the pigmentation within our blood. So if we have a laser that is highly absorbed by melanin or pigmentation within our skin or soft tissue and hemoglobin or pigmentation within our blood, you can imagine that that laser is going to be very good for cutting soft tissue and coagulating blood vessels. And that is indeed what diode lasers do very effectively, and that is why they're sold as soft tissue laser units, and that's why they specialize in soft tissue laser procedures. Now, one of the things I love about this pigment-seeking capability of a diode laser is in the hygiene periodontal arena. Here we are with these periodontally involved teeth where we've got this necrotic, diseased granulation tissue wrapped around these teeth that has been going away for a number of months or years under the calculus and tartar and the periodontal pathogens, and it's led to inflammation and endotoxin development, and we're losing connective tissue and bone in a chronic process that's going on over months or years. Now, the cool thing about a laser is we can go in and scale and root plane those teeth, remove the tartar and or calculus that is the barnacles on the pier type materials that are a physical irritant to the connective tissue and the bone holding the tooth into the mandible or the maxilla. And once we do the scaling and root planing, for the first time, we have a methodology to go in and selectively, and that's the key word, selectively target diseased granulation tissue, deeply pigmented tissues, remove them while leaving healthy tissue alone. And the way we're able to do that is we use a setting for your diode laser which is sub-surgical. In other words, it will not cut healthy tissue. So I, as a dentist, if I'm doing a frenectomy or a soft tissue crown lengthening, I would need to use, let's say, 1 to 2 watts of power to accomplish that kind of surgery. But my hygiene team, when they're doing laser curettage, they're using 0.4 to 0.8 watts, which would not cut healthy tissue, but will cut deeply pigmented necrotic granulation type tissue, which is highly vascularized and much more pigmented than healthy tissue. And no matter what ethnicity my patient is, there will always be a differential in pigmentation between diseased tissue and healthy tissue, with the diseased tissue being more pigmented than the healthy tissue. And that's why we use a range when talking about laser curettage of 0.4 to 0.8 watts. That allows us to just find that sweet spot where we're taking out the bad tissue and leaving the good. One of the reasons why I think diode lasers are especially useful in our hygiene periodontal departments, as much so, if not more so, than our surgical department of our practices. Now, lasers in medicine. I'm just going to show you some pictures here to show you some various things we can do with a laser. One of the cool things about lasers is their ability to go through tissues they are not absorbed by, go to their target tissue, and then have their effect. And so I'm including this slide to show you that there's some things I can do with my laser that would have been very difficult to do with traditional modalities. The top left of this slide, that is actually a human hair that you're looking at with these little notches cut out of it. Now try that with a 15-blade surgical scalpel, and you would find that to be very difficult to do. But yet it's something we can accomplish with a laser. I can go through and cut tissue and coagulate it. I can cut tissue and not coagulate it. I can melt two tissues types together. I can go through tissue that I'm not interested in or not targeting. In the case of a varicose vein laser, for instance, I can go to the varicose vein clinic. They have a laser that will go through my skin, my connective tissue, and any muscle and go to those very blue varicose veins. They will absorb the laser's energy, turn the laser energy to thermal energy, and they will sclerose or shrink or go away. So that's an evidence or an example of lasers transiting tissue to find their target and then being absorbed by their target and having their effect on it. And that's another reason we're seeing more and more lasers being used in medicine and dentistry as time goes by. Now, the next slide I'm showing you is what's called laser tissue interaction. Now, laser tissue interaction explains what can happen when you shine a soft tissue laser, or really any laser, at tissue. You'll get laser tissue interaction. Now, there's one of 4 things that will happen when a laser is put into tissue, and it spells RATS. So how I remember it is the acronym RATS, R-A-T-S. The laser energy will be reflected, so that's why we need to wear our safety glasses. It may be absorbed. It may be transmitted through the tissue, as in the case of the varicose vein laser, going through tissues to get it to its target tissue. So reflection, absorption, transmission, and the final thing that may happen to that laser energy is it may be scattered. Now, if you were to see a test question that said something along the lines of the following laser tissue interactions, which one is most important in order for a laser to do work? Reflection, absorption, transmission, or scatter, you probably know the correct answer for that would be absorption. because a laser must be absorbed before it can do anything. And that's why we always have to know the targets of our laser to figure out what it will be good for. In the last slide, I wanted to show you that there's an orange area in this slide, and that's where I'm cutting. There's a yellow area around the cutting area that's called the irradiated volume of tissue. Now, that is the tissue that is affected by the laser energy application to one degree or another. And there's only one time that we ever talk about irradiated volumes of tissue, and that's when we're referring to the phenomenon called biostimulation. Now, biostimulation refers to the fact that your diode laser has the ability to speed, enhance, and promote healing through the photonic energy going into soft tissues at low power settings and kicking off a cascade of events that lead to healing components being brought into your surgical area. Now, there's a lot of science and evidence-based dentistry on how biostimulation works. And it's pretty involved. And we're talking literally thousands of articles have been written on light's ability to speed, enhance, and promote healing. The good news for us as clinicians is that diode lasers are very close to the optimal wavelength for this biostimulatory capability. And just to give you some examples of how it's used in the marketplace today, most professional and college sports teams, their trainers will have these little devices that look like flashlights in their bags, and those devices are milliwatt powered lasers, and they'll use them on any sprains, injuries, soft tissue trauma, or tears to help that area heal faster than it would have and more completely than it would have. Another example is if I go to the orthopedic surgeon and I've got tennis elbow, they will rent me a device that looks like a flashlight, and they'll tell me to rub it over the affected area for a few minutes a day for a few weeks, and if I do, I'll heal faster than if I do not. And my insurance company will pay for the rental of that little device, which again is a little flashlight-looking device. It's a milliwatt-powered diode laser, and there are many companies throughout the world that's in their entire business model. They make biostimulatory lasers, which are milliwatt-powered diode-type lasers that come with different tips. Some as small as what we use, 400-micron fiber optics, which we use for surgery. They also have some tips that look like a composite-like tip. So bigger areas of diffusion of the light or smaller areas, depending on whether we're treating our TMJ, a post-extraction site, or a periodontal pocket. All three of those procedures would require a different delivery mechanism for our low-level laser energy. Now, biostimulation is kind of a very growing and a very lively field at this point. And so there's still a lot to learn about it. But I know of at least 4 names I've seen it called as I go to symposiums and I read laser textbooks. So I most of all usually see it called laser biostimulation. I sometimes will also see it called low-level laser therapy, or triple LT. I've also seen it called photobiomodulation, and sometimes it's called cold lasers. So those are 4 names for the same phenomenon, and that phenomenon is biostimulation. If you want to learn more about this, go on PubMed or Google, type in any of these 4 search terms, and you'll get more studies and evidence-based dentistry than you can possibly read in a reasonable period of time. Now, I've tried to do some work for you and take a lot of these studies and distill them down to their essence. And as I've looked through the literature and gone through it, to simplify this down, here's what I found. There's 4 basic components that will be increased after a biostimulatory application of a laser into soft tissue. And those 4 components are CCOF. 4 things that are increased post low-level laser therapy or biostimulation are circulation. Number 2, collagen formation. Number 3, osteoblastic activity. And number 4, fibroblastic activity. So osteoblast, of course, being bone-building cells, fibroblast being connective tissue-building cells. Where is that most important? In our perio cases. So after we go in and scale and root plane, and then we use the laser to do curettage and selectively remove diseased tissue lining the epithelium, at the same time, we're killing the bacteria that cause this disease, in other words, the periodontal pathogens, and we're spraying low-level laser energy right at the bottom of that pocket where we've got that diseased lethargic tissue that's been resorbing for a number of months or years under this bacterial onslaught, and the diode laser is the only way I know of to stop that recession, to arrest that recession, and to actually kickstart or rejuvenate or revitalize reattachment back up the root. And as we all know, we've been taught in dental and hygiene and professional schools that the best that we can hope for when treating periodontal patients is to stop the disease and maintain the patient where they are today. But that we will never get vertical or regenerative growth of tissues, be they connective tissues or bony tissues, back up root surfaces. So this is a huge benefit and advantage and a paradigm shift in our periodontal thinking to actually see that we can positively affect bone levels through laser periodontal therapy as opposed to our traditional methodologies. So that's one of the areas where I'm most excited about this biostimulation component of our diode lasers. So we'll go to the next slide, and we're going to talk about procedures that you can do with your diode. In other words, specifically soft tissue procedures, let's say surgical type procedures. Now, when most people buy a diode laser, they compare it to an electrosurge, because what we're seeing happening as we see this explosive integration of diodes into dental offices is many times an electrosurge is ready to be replaced, and the dentist, instead of automatically buying a replacement electrosurgical device, which also cuts and coagulates and cauterizes and sterilizes wound edges, they look at the laser because it'll do those same things, but other things as well. The advantages of the laser: it's a bit more expensive, and here's why we're willing to pay that extra money, is you can use the lasers around metal. Now, because they're not an electrical device. Yes, they're an electrical device on the tray table, but all you're moving into the mouth is light and or heat. So I can use it around crowns and bridges, dental implants, dental instrumentation, pacemakers, and those sorts of things with no negative sequelae or no issues. So the ability to use a laser around metal is huge, especially with implant dentistry. If I wanted an implant to fail when I was working with implants a lot, all I would do is take an electrosurge and touch the implant, and invariably it would start a failure mechanism. And when I was at LSU, we studied failure mechanisms of dental implants, and we instituted the failure by taking an electric surgical device and zapping that implant, and then studying how the soft tissue would invaginate around it, it would become loosened and lost. So I never wanted to use an electrosurge around an implant, but I'm quite comfortable using my diode laser to remove tissue, sculpt tissue, get good impressions and good temporization on my implant cases. Now, the second advantage of a diode laser versus an electrosurge is the zone of necrosis issue. An electrosurge has an average zone of necrosis of 500 to 1,000 cell layers deep, which means in the past, when using electrosurges for aesthetic recontouring prior to doing preparations and impressions for veneer cases, we were forced to do our pre-prosthetic surgery, dismiss the patient for 4 to 6 weeks for healing to take place, in other words, shrinkage to take place. Then the patient would come back in, we would see where the soft tissues ended up, then we would prep and we would impress. Now, that's a scary thing, because when you let a patient go for 4 to 6 weeks, a couple of bad things can happen. Number one, you worked so hard to get symmetry in those centrals the exact same height, and then the same height as the cuspids. They come in 4 to 6 weeks, maybe you only got 1,000 layers of cell necrosis on one central, and the other one even had less. It only had 500 cell layers of loss. And so now they're not symmetrical anymore. And through no fault of your own, you've got an issue. Or sometimes during that 4 to 6 week between pre-prosthetic surgery and preparing the teeth for the veneers, the patient will buy a big screen TV or a new truck and decide not to go forward with their restoration. Sometimes they'll look in the mirror and they'll be, you know what, that's enough. I'm okay. So one of the things we have really liked, and I see the American Academy of Cosmetic Dentistry members and all of these high-dollar aesthetic dental courses like Rosenthal and Rinaldi and LVI and Pankey and the Hornbrook Group, anywhere that teaches you to do beautiful aesthetic veneer cases in the maxillary anterior area, invariably, during the hands-on, when you bring your patient in to do your preparations, they will bring a diode laser around in a cart. They will hand it to you, and before you prep and impress, you will take a diode laser and you will recontour the soft tissue contours of that aesthetic area and get them right out of the textbook. Centrals the same height as each other and the same height as the cuspids. Lateral slightly shorter, everything angled toward the belt book, and the tissue stays where you put it. As I mentioned, an electrosurge has a zone of necrosis of 500 to 1,000 cell layers. A laser has a zone of necrosis of 3 to 5 cell layers, which is less than a human hair. So I call that what you see is what you get, WYSIWYG. And so one of the great advantages of owning a diode laser is your ability to do soft tissue surgical crown lengthening and the tissue staying right where you put it, so you can prep and impress the same day you do your surgery. Thirdly, the electrosurge is not able to do things like periodontal applications. The laser allows me to do perio, whether that be laser decontamination of sulcuses to eliminate the vast majority of periodontal pathogens, or using the laser to selectively target diseased tissue, remove it while leaving healthy tissue alone. So I've got perio applications with a laser I don't have with an electrosurge. I also have the ability with my laser to desensitize teeth, to treat herpetic lesions or aphthous ulcers, and also I've got marketing benefits with a laser I do not have with my electrosurge. No one will call you and say, hey, I'd like to come in and see you today because I hear you have an electrosurge in the office. Or I hear you have a 15-blade scalpel. I've been told I need a frenectomy, and I want to come right in right away before that scalpel gets old or rusty or dull. But people will come in and call you because it says laser dentistry on your website or your business card or your external signage, because the perception of laser dentistry is the highest technology, highest care available, at the most gentle way that you can do it. And they realize that clinicians that own lasers have spent extra time and money to provide best care available, and they appreciate that. And so you will find new patients will seek you out because you're a laser dentist. And remember, as of today, only 17% own them. So, 83% of the other dentists in your community don't have them. So if you get one today, you'll be ahead of the pack. You can establish yourself as the laser dentist in your area. Wait 3 years or 4 years or as long as 5 years, and over half of our profession will own a laser. And that means it'll no longer be a competitive advantage for you as it would be if you were to get it today and be considered an early adopter. Now, how we do desensitization and treat herpetic lesions and aphthous ulcers. Now, these are all things my hygiene team can do. My hygiene team can do 6 things with a laser. They can whiten teeth, they can treat herpetic lesions, aphthous ulcers, they can desensitize teeth, they can do a procedure called laser bacterial reduction, and they can do a procedure called laser curettage. So there's 6 things that hygienists can legally do with a laser in the 36 states that they're allowed to use a laser. And these are all things that are value-add procedures for the hygiene department and allow them to help patients to a greater degree than in the past and to produce more revenue in each hygiene room. So these machines far more than pay for themselves while helping you to provide greater quality of care than our traditional modalities. Now, I've included on this slide the basic methodology to do desensitization of a tooth, a herpetic lesion, or an aphthous ulcer. And I included just to show you how simplistic it is. For acute localized sensitivity, all we'll typically do is we'll use the laser at about 1.5 watts for 90 seconds. And then we'll check the sensitive spot. If it's gone, we're done. Average fee, $45. We usually use $99.10, which is desensitization of teeth via topical medicament. And after we use the laser, we'll put a little paint on desensitizer so that we don't go to insurance jail. And this is something that my hygienist can do. And many times they need to, because they're blamed for causing sensitivity because they remove accretions off the teeth that expose root surfaces to the light of day. Now, herpetic lesions and aphthous ulcers, they're amazing in that. I thought, you know what, they can't be as good as everybody's telling me. It just can't be. But I have personally gone through and seen that they do work both on myself and my mother-in-law. I was treated 3 times over the course of my first 2 years of my laser, and I have not had a herpetic lesion breakout in over 10 years now. Now, I'm not saying tell your patients you've cured them of herpes, because we all know that there is no cure for herpes, but I am saying if you treat the same person in the same place multiple times, I and many other clinicians are seeing that that lesion doesn't come back to that area, or really in my case any other, or my mother-in-law and any others. She used to get them right by her philtrum. They would go all the way up into her nose, and she even had one on our day that Malia and I got married. And so a lot of pancake makeup and a lot of Photoshop. But the one thing I've done in 15 years of being married to her daughter correctly is I treated her 4 times in 2 years, and she hasn't had a breakout in over about 9 years now. So you will find yourself very popular with your friends and family and your patient population when you can treat herpetic lesions. And if I treat them before they break out, in other words, during the prodromal phase, I would say 95% of the time I can keep them from ever even showing up at all. So this is a great boon to your office. Now, another thing that we can do is we can do soft tissue surgery. So minor soft tissue surgeries bloodlessly and without using sutures, which for me was a huge thing, because I'd learned just enough about frenectomies in dental school to know I didn't want to do them when I got out. Because at my dental school, we had to scrape the periosteum with a scalpel and sew the area up, and neither one of those was I comfortable doing. And so most articles say that frenectomies are one of the most underdiagnosed procedures in dental offices today, and that as many as 1 out of 7 patients can benefit from a frenectomy if we're looking for them and diagnosing them properly. And far better to do a minimal frenectomy and stop recession than to wait till a patient must see a periodontist and get a connective tissue graft, because that would be a disservice to our patients. So now, even I, a product of the Arkansas public education system who doesn't like blood or sutures, can do frenectomies in 30 to 90 seconds with regularity. Average fee is about $550, 80% insurance coverage, 20% out of pocket. So here will be some before and after. So here's a before, and then here is an after. Now you'll notice here, this is 6 teeth that needed a gingivectomy and a gingivoplasty. We also did a frenectomy. We also replaced some old composites. And now we got a lot better result than if we had just replaced the composites. And the thing about dentistry today is all of us are cosmetic dentists. Nobody puts their name under, hey, no, I don't do cosmetic dentistry. I'm the ugly dentist in your town. So we're all expected to fill holes within teeth as well as to pay attention about holes between teeth, in other words, missing teeth, and to take care of aesthetic contouring for maximum aesthetic outputs with our patient. And the diode laser makes that much easier to do. So I did an immediate post-op. This is a 2-week post-op, and you can see we got a lot better result than we would have had we just done the restorative and not done the soft tissue. Now, these were 6 teeth of soft tissue crown lengthening at $225 a tooth, a $550 frenectomy. So this was $1,900 in soft tissue work with no lab fee in about 20 minutes. And then the composites, happy patient, happy office. This was a win-win for everybody as far as being able to do this with our laser. A couple more examples of frenectomies. Again, these are very common. Every day your hygienist will see at least one patient that could benefit from a frenectomy. So here we have a maxillary anterior and lingual frenectomy pre-op, and then here we're going to go to post-op. So you can see that we just start right where it attaches, and then we will, as a post-op, show that we started here, came down, and we end up with a little kind of a chocolate chip or a diamond shape post-operatively. And that diamond shape is what our dental schools taught us to look for. So we start at the top, right where it attaches, take it to the floor of the vestibule. As we keep firm pressure on the lip, it'll open up in a diamond shape, and then we're done. I'll usually take some vitamin E capsule, break it open, massage it into the site, and that is a soothing emollient and antioxidant that we use traditionally with our surgical procedures with our laser. Now, little clinical pearl for you here. A minimal frenectomy, the downside is 1 out of about every 20 will get enough reattachment that you'll need to redo the surgery to one degree or another. And that's why many specialists advocate going all the way to the bone level and scraping the periosteum to create a scar that will prevent that reattachment from taking place. And I used to have to redo maybe 5% of our cases. And even then, that was a win, because I would rather redo 1 out of 20 than overdo 19 out of 20. But a few years ago, we started a procedure which I think is the bomb now. Anytime I do a frenectomy and there's a potential for reattachment to take place, we'll send our patient home with 20 vitamin E capsules. And we'll tell them starting tomorrow, every morning and every evening, to break open that vitamin E capsule, put it onto their washed finger, their clean hand, and gently massage it into the surgical site to prevent reattachment. And since we've been doing that procedure, we've had 0 cases that we've had to redo because of a reattachment issue. So the next slide is a maxillary frenectomy. So you can see we're going to start right here where it attaches. So you start cutting right in the zone of attached tissue, right by the 2 teeth. Here it's interproximally. We work our way to the floor of the vestibule. You'll be able to see post-operatively how I've got sort of that diamond-shaped look that we were taught to see in our dental school classes post-operatively when doing a frenectomy. Now, in this particular case, there's a little bit of tissue right up here above my diamond-shaped incision area, and that little tissue is going to either need to be removed or it will resorb. And that is something that will take you a little bit of clinical discernment to learn whether or not you need to cut that off or whether or not the body will resorb it. And it's all dependent upon the size. So what I typically tell people is when you first get your laser, let's take the low-hanging fruit. That's the upper right, the upper left, lower middle, and lower right frenectomies. Those are very easy with no reattachment issues and no real big clinical judgment or anatomical issues we have to deal with. And only after you gain experience and go through maybe an advanced course would I recommend you do maxillary anterior frenectomies or lingual frenectomies, especially with fibrous tissue going between 8 and 9 and the vital structures, shall we say, that exist underneath the tongue. So make those your last cases. Take that low-hanging fruit first. Now, in an average week, you'll probably see at least 1 or 2 of these, because again, every day your hygiene team can have a conversation with at least one patient about the fact that they've got recession in an area and it's caused by a little frenum attachment, and that you can clip that with your laser comfortably and quickly and bloodlessly. Now here is a mandibular frenectomy where it's on both sides. And typically if I see anatomy on one side of a patient, they'll have identical anatomy on the other side. This patient, their frenums attached in the zone of attached tissue on both sides. So we just took them down to the vestibule on both sides. So this was a double frenectomy done in 5 to 10 minutes. And it was a win for the patient and for the practice. We'll see that we've got the post-op on this dual lower frenectomy case. Now, uncovering an implant is something I would not do with my electrosurge because I don't want to cause it to deintegrate or fail. But now, if I take a healing abutment off of an implant and tissue has grown between the healing abutment and the head of the implant, I can take my laser, remove that tissue, get a fixture level impression, put my healing abutment back in, and everything moves on smoothly and easily. Where in the past, if I took a healing abutment off a osseo-integrated implant in the bone and tissue had grown between those two elements, I had to get a scalpel out or send them back to the periodontist or oral surgeon to have them deal with that, and that put all of our schedules back a couple of weeks. So I love having a diode laser for implant contouring, impression taking, and the ability to work around the implant without concerns of causing deintegration. So you'll see we've uncovered the implant. We have the top of the fixture exposed. We'll take a fixture level impression, and in this next slide you'll see that we have the healing abutment in place while we're making the restoration. So implant dentistry, next slide, is a wonderful place to use your laser. Now, troughing. Many clinicians will buy their soft tissue laser because they're tired of packing cord. And packing cord is no dentist's favorite thing to do. And when you pack cord, you're trying to stop bleeding, dry up any crevicular fluid, and create a little space for impression material. And you can do that quite easily and effectively with your laser. And actually, it works better than cord in most cases because you have a longer working period before the crevicular fluid will go back into the sulcus. This is an example of using a laser for troughing around crown preparations. This is especially helpful for our optical impression type cases where we may be doing CAD/CAM type dentistry and we need to be able to visualize all our margins with a scan from a handpiece laser, and you've got to see all of your margins with no tissue hanging over them. So CAD/CAM dentistry and lasers go together like peas and carrots. They're a very good fit. So the next slide here, we're going to show you some videos. Now, I've got a gingivoplasty, a troughing, a granuloma removal, and an operculectomy. So I'm going to hit the button, and the next thing you'll see is we're going to do a gingivoplasty, which basically means, thinning out gingival tissue. This is a class 5 gingivectomy. So here we have decay that has gone subgingival, and we need to remove the tissue out of the way enough so that I can do a good composite and get a good seal and end up with a very good restoration instead of a cruddy restoration, chewed up tissue, and bleeding into the area. So now I get a gingivectomy and a class 5 instead of a subpar class 5 restoration. So here's somewhere the laser helps us be a better dentist, helps us do better service for our patient, and increases our profit potential for this kind of restorative case. And that's a 2-day post-op that you saw there. Here's another case with using the laser to trough instead of packing cord. So here we're taking our laser and we're going around creating space for impression material, stopping bleeding, and creating room for your impression material. One thing I would tell you is do about 1/6 of the prep at a time in an overlapping manner, and that'll work better than doing big circles when you're troughing with your laser. And this is a very common procedure and a very good use for your laser. The next thing you'll see is a granuloma removal. Here I have an interproximal overgrowth of tissue that's a granuloma. I can remove that with my diode laser quite effectively without bleeding or sutures. We go in, we just simply undercut this granuloma, and we remove it, and you will see that as we undercut it and take it away, no bleeding, no sutures, not having to suction blood and heme away, and good visibility. And I'll also be able to show you a few days post-op on this case, and you can see we get great soft tissue healing post-operatively. So here we're using 1 to 2 watts of power, continuously firing with an initiated fiber, and we are undercutting this, and you will see that once we remove this, that we'll be left with that cauterized bed of tissue underneath it. So we're denucleating this and removing it. And then we'll have a post-op to show you how quickly and how well it heals. And then this is immediately post-operatively, and then this is a 2-day post-op, and then a 1-week post-op picture showing how excellently the soft tissue heals. Now, operculectomies, of course, are where tissue grows onto the occlusal table of a tooth, many times being bit over and over again, leading to inflammation and chronic pain for a patient. And here we have a molar where the retromolar pad had grown up and over and onto the occlusal table. So we'll use a 5 to 7 millimeter long fiber. We'll use about 1.5 watts of continuous power. We'll initiate it extremely well, and we'll go in there and we'll remove all that tissue to the distal of that molar in that thick retromolar pad area, making sure we remove the tissue below the suprabulge of that tooth, so that over the next week or two, as it heals, it will heal below the suprabulge, and the bulge of that posterior part of that tooth will keep that tissue from going back up above that area and getting back onto the occlusal table. So operculectomies are another application here for our diode laser. Okay, we just finished soft tissue surgical procedures and some basic physics and safety type information on the lasers, and now we're going to move into laser perio. And as I had mentioned earlier, in my opinion, the laser periodontal aspects of these diodes or these diode lasers are truly some of the most innovative and unique things you can do with a laser. So the things my hygienists do with a laser is the most exciting part of laser dentistry, because you can't do this stuff really any other way. Now, there's basically two things I'm going to need to teach you in concern to laser periodontics. But first, I wanted to share with you one of my first, so that as you're doing your soft tissue crown lengthening cases, I thought I'd show you one of my first cases. And this is why I always tell you that when you're doing your first crown lengthening case or two, you may not want to do an anterior case. So actually, this is a pacifier, which probably every dentist or hygienist on the planet should have to give to people that have new babies. So when we come to laser periodontics, again, as I mentioned, there's two basic things I want to teach you here. Number one, laser bacterial reduction. Sometimes you'll hear it called laser decontamination. And secondly, laser-assisted periodontal therapy. Now, LBR, laser bacterial reduction, is a procedure I do at two separate times with patients. Number one, and this may rock your world a little bit, but number one, we recommend doing LBR before every patient's cleaning appointment. So all adult dentition patients, when they come in every 3 months or every 6 months, the first thing I want my hygienist to do is to take the laser at 1.5 watts of pulse power with a non-initiated tip, take a 0.5 millimeter of fiber, put it into the sulcus, and sweep all the buccals of the maxilla and all the linguals of the maxilla, and the same on the mandible. It's a 5 to 10 minute procedure. It's a painless procedure, and most patients tells me that it feels like I'm taking an Explorer and tracing the outline of their sulcuses. And what I am doing is I'm spraying laser energy into those pockets and killing those bacteria. So it's not necessary to touch the bacteria with the fiber. You just want to spray laser energy onto them to kill them. So kind of think of this like shining a flashlight down into a well. Anywhere that light energy hits, you're killing bacteria. And actually, if you go more than a 0.5 millimeter or so into that pocket with your fiber, you're actually passing bacteria that you could have killed had you not gone beyond them when performing laser bacterial reduction. You're also more likely to cause discomfort for your patient the more fiber that you put into a sulcus. Now, I believe that laser bacterial reduction is one of the easiest things that we do with our laser within our practices. So I highly encourage that your hygienists do this to a friend and have it done to them so that when they're talking about it in the future, they're speaking from a position of knowledge. Now, so we do LBR before every cleaning appointment, and then LBR is also one of the steps we perform when we do laser-assisted periodontal therapy. So now, we'll talk about LBR first. As I mentioned, 1.5 watts, pulse power, non-initiated tip or a non-pigmented tip, 0.5 millimeter into the sulcus, sweep all the buccals and linguals, and a diode laser will shoot 6 to 9 feet from the tip, and most periodontal pockets are less than 6 to 9 feet deep. Even here in Arkansas, most periodontal pockets are less than 6 to 9 feet deep. So unless we've got a mechanical obstruction, we should be able to get our laser energy all the way to the bottom of that periodontal pocket. Okay? This is typically a 5 to 10 minute procedure. We charge $30 to $50 for it. And we have about when we first started, about a 70% success rate, and now about an 80% plus success rate of patients having this done. One of the things that has raised our success rate is as time goes by, when people come in and have their teeth cleaned, they go back to school or to work and they tell their friends or their schoolmates, I had my teeth cleaned and they did a laser cleaning. Now that's not what we did, but that's how students and patients describe it to their friends because it's something different. And anyone in their circle of friends that is into high-tech dentistry or the best care available goes, you had a what? And they said, well, they used a laser during my cleaning appointment. So our phone starts ringing, and it's people wanting to come in and get one of their laser cleanings. So when they walk in our office, we don't have to talk them in to having laser bacterial reduction done. They chose our office because we do that. More hygienists have wanted to work for us. They see that we seem to have what, in their opinion, is a slightly higher level of hygiene care because of the institution of the lasers into our hygiene program. And here's been probably the biggest difference it's made for us. Before we started doing laser bacterial reduction, maybe 40, 50, 60 patients a year knew we were a laser dental office because we used the laser on someone for a surgical procedure. But since having the laser and using it for laser bacterial reduction in the hygiene room, now 75-80% of the practice is exposed to the laser as part of their cleaning appointments. So 2,000 people for our average patient chart practice times 75-80% is 1,500 to 1,600 people a year going out into the community and talking about the fact that you are a laser dental office. And people tend to associate laser dental offices with high-tech, high-quality dentistry and the most painless, up-to-date care available. They also tend to tell us in our focus groups that they expect us to be above average in our fees and that they're okay with that because they think we represent, again, top-notch care. We've paid extra money and time to go and learn about the latest and greatest care available to them. And so even if in some areas we might have not have kept up, owning a laser tells patients that you're a cutting-edge dentist or dental office who's caught up with the latest technology or keeping up with the latest technology. Now, change the world. So here's where I'm sort of, getting a little crazy, and I'm saying, in my opinion, if you live in a state where your hygienist can use a laser, I would highly recommend that you have them use it on every cleaning appointment every 6 months or every 3 months for adult dentition patients. I've got a sheet on our website that says Patient Introduction to Laser Bacterial Reduction. You can go on our website, advancedlasertraining.com. Go under Laser Library. It's a Microsoft Word document. You can take it. You can change it to your own wording and your own pricing and make it your own. Give it to your receptionist. When people come in to get their teeth cleaned, they get that. They read it. They sign it. It goes in the chart, becomes a normal part of what they have done moving forward. This will take some of the load off of your hygienist in explaining this program and getting the informed consent signed to do these procedures and to make sure the patient understands it's an out-of-pocket versus an insurance-covered procedure. Now, why do we recommend this? Why would I tell my patients I think it's worth them to spend $40 and 5 or 10 minutes of their valuable time to have this done? Well, there's 3 basic reasons we recommend this. Number 1, we want to reduce or eliminate bacteremias. Now, as we discussed earlier, the literal definition of the word bacteremia is a flood of bacteria through a break in the mucosal barrier. So no matter how gentle I am when I'm cleaning your teeth, at some point, somewhere, you're going to bleed. And when you do, the bacteria that are in that area will go bloop down into your systemic circulatory system. And if you are healthy and you're not immunocompromised, your immune system will clear that bacterial assault in about 20 minutes with no negative sequelae. But if you have an issue like a narrowed vasculature situation, they can settle or cause inflammation and lead to strokes or heart attacks, which are 2 of the biggest sudden death killers in the U.S. So that's kind of a big deal. They also can settle and cause subacute bacterial endocarditis. If our patient has an artificial knee or hip, they may settle in those areas and cause secondary infections to those implants that have been put in. They've been tied to rheumatoid arthritis, low birth weight babies, diabetes, and again, 29 separate systemic disease states have been tied to oral infections, and anything we can do to limit them is extremely helpful for our patients. Dr. Oz did a show the other night. He had 10 people on that had had emergency bypass surgery. The first 8 people, he would pull their chart with Oprah in the hall before they would go in, and they would say, smoker, high blood pressure, previous heart attack, high cholesterol, family history. And you're like, okay, not that big a surprise that one minute they're walking down the road and the next minute they're waking up and they've taken veins out of their legs and they've wrapped them around their heart. And that's kind of a big day in anybody's life. But they got to patient number 9 and they didn't have all these predisposing factors. And everybody, it's a 58-year-old African-American male. And we're all like, well, what happened? Why, if we don't have this, this, and this, and this, did this person end up with emergency bypass surgery? And so Dr. Oz had the patient open their mouth. And you know what we saw? Massive periodontal disease. I mean, the teeth in this patient's mouth basically were just in by the nubbins, by the very end of their root surfaces. And the most of all the root surface as well as the clinical crown was exposed. The root surfaces had, barnacle, tartar, calculus all around it. And Dr. Oz said, most of the time, if I don't see traditional risk factors, I will see this, or this will be one of the risk factors. And so for that particular patient, that bacteremia, where the bacteria went to the liver and caused C-reactive proteins, which lead to inflammation, was enough to cause this person to have a heart attack. Now, I take baby aspirin every morning because my cardiologist tells me if I'll take a baby aspirin every morning, I've got a 1/3 less chance of having a heart attack than if I do not. And there's two reasons for that. Number one, he says the baby aspirin is an anticoagulant. So he's already saying, Chris, I know you were born with arteries this big. You've eaten bacon for 40 years and now they're this big. You get your teeth cleaned, you get a bacteremia, you get C-reactive proteins made by your liver leading into inflammation, and now that artery could go to this big. And that could be enough to cause a stroke or a heart attack. But I'm going to help you. I'm going to give you a baby aspirin every day. So here's your artery. 40 years of bacon takes you this. You get a bacteremia and you get inflammation, but since you've got aspirin on board, the inflammation is reduced. And so instead of going from here to here, it maybe goes from here to just here. And the aspirin's an anticoagulant as well as an anti-inflammatory, which means even if I have thinner vasculature, the thinner blood can move through the narrowed vasculature and still allow me to do what I need to do as far as blood getting to my organ systems. So, baby aspirins, if you're over a magical age, are supposed to lower your heart attack risk by 33%. Second point I would make on that. If you go to an emergency room with undiagnosed chest pain, the first thing they will give you is 4 baby aspirin and tell you to chew them up even before you start filling out paperwork. It's the single best thing you can do for yourself to help you hopefully survive a heart attack. So, my good friend, my cardiologist said, Chris, I want you to carry 2 adult strength aspirins in your pocket. And if you ever feel like you're having a heart attack, pop them in your mouth, chew them up, and get them down. You don't want any enteric-coated aspirin. You just want plain, bare type, white, round pill aspirin with no type of coating, 325 milligrams each. You want to pop them, chew them up, and they'll taste horrible, and get them down because it's the best thing you can do for yourself. And if you're awake when the paramedics get there, it's the first thing they'll do for you and that they will give you. So I would recommend you do that. And the life you save might not be your own, but you might save someone that you see out in the workplace or world who is undergoing a heart attack. And if you can get those aspirin on board as soon as possible, you may be the one that makes the difference whether this person survives or doesn't. Now, the second reason we want to do laser bacterial reduction before we clean teeth is to reduce or eliminate cross-contamination. I don't want my hygienist to go into the distal buccal of number 3 where that 7-millimeter pocket is, pick up periodontal pathogens, and then do what with them? Inoculate the entire rest of the mouth with them, spreading the disease. So if we can decontaminate before we clean, we reduce or eliminate cross-contamination with our instrumentation. The third and final reason we recommend laser bacterial reduction prior to cleaning teeth is we want to kill potential periodontal infections before they have an opportunity to cause loss of attachment. As you'll recall, in order to get periodontal disease, you must have periodontal pathogens at a specific level for a specific period of time. And depending on your genetics, that level and that amount of time will vary. But if every 3 months, when your patient comes in, every 12 weeks, they're coming in, you can kill all potential periodontal infections. You're never giving those pathogens more than, it takes 4 to 6 weeks for them to repopulate. So 6 weeks later, they're at full strength. You're never giving them more than 6 weeks to work on that attachment level and cause active disease. Now, since instituting laser bacterial reduction, we've seen far fewer patients convert from someone we've treated for periodontal disease and they've got 3-millimeter or less pocketing back to active periodontal disease. And I believe that's because when we kill these bacteria every 12 weeks, we know it takes 4 to 6 weeks for them to come back up to pre-decontamination levels, and then they've got a maximum of 6 weeks, if they do that, to work on the attachment levels. And for most people, they need those pathogens at a critical level for a critical period of time, and that critical period of time is longer than 6 weeks. And if you don't do this, here's what happens. I go see Susie, my hygienist. She cleans my teeth. I've had soft tissue management program in their office. At my first appointment, I'm 3 millimeters or less, no inflammation, no bleeding. Susie says at the end of the appointment, "Great, you look good, Chris. I'll see you in 3 months." 3 months later, I come in, I got 4s, 5s, inflammation, and bleeding. So what happened? Well, what happened is I developed periodontal disease. How did I develop it? Well, I've had periodontal pathogens in those areas long enough at a high enough level to induce loss of attachment, inflammation, and bleeding. And you see, when I saw Susie 12 weeks ago, she didn't kill them, so they did not have to start over, and so I got active perio. But if she 12 weeks ago had gone in with the laser and decontaminated all my pockets and killed any potential periodontal infections that may have been in place, they would have had to start over. So I would submit to you that when you see somebody go from healthy to perio patients, and they're on your 3-month recall, chances are when you find the 4s, 5s, inflammation, and bleeding, that 3 months before when they were in, they had periodontal infections in all of those areas that are now 4s and 5s, inflamed and bleeding. But our problem as clinicians is we can't see the infection. We can only see its results, which is loss of attachment, inflammation, and bleeding. So therefore, if we had killed them 12 weeks ago, much less chance that now they've got active disease. So another reason we do this is to kill potential periodontal infections before they have an opportunity to cause loss of attachment. Those are the 3 reasons we recommend doing laser bacterial reduction on our adult dentition patients prior to cleaning their teeth. And as I mentioned, we've got about an 80% or so success rate. We have 2 groups who say no. We have one group who says, if insurance don't cover it, I ain't going to do it. We all have those people. We have another group who says, I've been coming here for 25 years and you've never done it before in 25 years, so why am I going to do it now? And of course, we're always telling those people that as we learn better, we do better, and we have more knowledge and more tools than we used to have, and now we adjust our treatment recommendations and modalities just like we would want ourselves to be treated. Because I think most of us dentists and hygienists treat our patients the way we would want to be treated if we were the one in the chair. So this is something that you need to know about. You'll see it out there. You'll hear a lot about it. And if you become a laser owner, this is something that you most likely will do if you're in a state where your hygienist can use a laser. And if you're not, when I do your training course, I'll teach you ways to get around that so that you can still employ this in your office, but we'll have to just modify the technique for you. Guided tissue regeneration. And this basically is sort of all of what laser perio comes down to. So I'm going to give you the secret to laser perio right here in a simplistic manner because I'm from Arkansas. The way healing works is it's a cellular race between soft tissue and connective tissue and bone. Now, in the past, we've paid no attention to that fact. We've done scaling and root planing and curettage. We've done it one time and that was it. And that's why we always thought that the best we could hope for is to stop the disease and stabilize it. But if you pay attention to the fact that epithelial tissue grows faster than connective tissue or bone, soft tissue grows about 0.5 millimeter a day, bone or connective tissue grows about 0.08 millimeters a day. And to Arkansas that out for you, soft tissue is 7 times faster than connective tissue or bone. So if you want connective tissue or bone to win the race, you've got to continually pick up that rabbit versus your turtle, and after it takes off from the starting line, you got to pick it up, put it back at the starting line. It runs forward, you pick it up, you put it back at the starting line. And the whole time you let the turtle, connective tissue and bone, continue to go down the course and give it an opportunity to win the race. So the way we do that is when we de-epithelialize the inner lining of a pocket, if we did nothing, that soft tissue would go right back down the inner lining of the sulcus until it touched the tooth. You'd get a long junctional epithelium and you would get no more vertical reattachment of bone or connective tissues. If you want that to happen, you must repeatedly de-epithelialize the inner lining of that pocket over and over again to allow connective tissue and bone to come up before soft tissue comes down and stops it. And all laser periodontal procedures and recipes boil down to that basic fact. And the only difference is how do we keep the soft tissue out of the way long enough for connective tissue and bone to come up before the soft tissue comes down and stops it. and there's a few different methodologies. In diodentistry, we use repeated deepithelialization of the pocket with our laser. Guided tissue regeneration, or GTR, refers to procedures attempting to regenerate lost periodontal structures through differential tissue response. Kind of like my orthodontist. My orthodontist wants to see my children when they're 9, 10, 11, 12, 13, 14 years old and they haven't had their growth spurt yet. To continue the regeneration process, the first principle evolved from periodontal wound healing studies that found that gingival tissues migrate rapidly into most types of periodontal wounds. This type of healing forms a long junctional epithelium. This prevents regeneration and stops vertical pocket resolution from the bottom up. Most periodontal wounds heal in this manner. This form of healing is considered repair and not regeneration because the original architecture and function is not restored. And that's what we found with traditional perio cases. So, GTR, guided tissue regeneration, is using biology to achieve optimum results for our patients. Laser treatment protocol, how do we do it? Why are we using a laser and what can we do? Well, here's a patient education brochure. It explains in patient terms why we're using a laser to treat their periodontal case. This is the inside of it, and this, again, you can get at advancedlasertraining.com. We have a full set of soft tissue laser training brochures to help you explain to your patients why you bought the laser and what you're using it for. Now, laser-assisted periodontal therapy accomplishes basically 4 things. So every lecturer you listen to, every textbook you ever read is going to boil down to basically 4 bullet points. So we had laser decontamination, which was killing bacteria within the sulcus. And then our other thing is called laser-assisted periodontal therapy. And remember, this is your current soft tissue management program and adding the laser for what the laser can do. 4 basic things we accomplish. After we scale and root plane, we do number 1, and that's called laser curettage. Key word with laser curettage is selective. I am selectively removing diseased, deeply pigmented, necrotic tissues while leaving healthy tissue alone. It's a standalone procedure. Step 2, Step 3, and Step 4 happen simultaneously. Step 2, or the second thing we accomplish, is called laser bacterial reduction, taking the periodontal count of pathogens from 10 to the 9th, or billions, down to the hundreds level by using the laser to kill bacteria. Third thing we're accomplishing is called biostimulation, and we're spraying low-level laser energy at the bottom of that pocket, and we're increasing circulation, collagen, osteoblast, and fibroblast activity right where we need it most, at the bottom of a periodontal pocket. I can rejuvenate or revitalize or kickstart that reattachment process. The final thing that we accomplish with laser perio is called guided tissue regeneration, and again, that's referring to repeatedly de-epithelializing the lining of the pocket to keep the epithelium out long enough for connective tissue and bone to come up before the soft tissue epithelial downgrowth comes down and stops it. So that's what we mean by guided tissue regeneration. Typical appointment, there's 8 steps. We'll leave them in here. You numb them, you do the decontamination, you scale and root plane them, you do curettage, you do decontamination again, you lavage them, and then you give them their oral hygiene instructions. And that's what we do in an average periodontal patient. After I'm finished with my active periodontal case with my laser, so whether it's 1, 2, 3, 4, 5 appointments, however long it takes me to do the full mouth scaling and root planing and using the laser for what the laser can do, when I'm finished with that soft tissue management program with the laser, in other words, my laser-assisted periodontal therapy program, I'll let them go for 6 weeks. 6 weeks later, I ask the patient to come in, and basically what I want to do is just to see how are they doing. How's the oral hygiene going? Are they following our instructions? And if at that point I see any visibly inflamed areas around any teeth, that lets me know 2 things. Number 1, it lets me know that I'm probably having too hard of occlusion on that tooth, and I need to relieve that occlusion because, periodontal disease can never heal, or those teeth can never tighten up if they're being banged on and allowed to move around with micro movements. You break an arm, you have to put the arm pieces right back together and cast them so that they stay intimately connected with no micro movements. If there's any movement at all between the ends of that bone will never heal. Same thing with periodontal teeth. If you want bone to come back up teeth, those teeth have to be still. If they're moving around, you'll never get reattachment. And that's why occlusal control is so important in our periodontal cases. And that's what we do at the 6-week recall. We make sure our occlusion's right, and we go through our oral hygiene, and we build in that fee in our upfront fee usually. And then 6 weeks later, now this is 3 months post-active therapy. Now I will probe. Now I will give them their report card. And now we will celebrate with them the results that we've gotten. On the rare occasion, if we do have a failure, it would be now that we refer to our periodontist because what we're doing isn't working. Now, here's some crazy cases I'm going to show you. These are not cases I recommend you do. I'm showing you these cases to show you if this can be done for these crazy cases where really we should have had extractions done, imagine what you can do for your 4, 5, 6, and 7s. This should have been extracted and bone fill and maybe an implant. This patient was not able to afford the extraction and an implant and restoration. They begged us to treat it. We did just to see how it would go. And they knew that we were just sort of trying this out and pushing the envelope. Here's the same tooth 8 years later. Now, first of all, this tooth being in the mouth 8 years later is a miracle. But here's the same tooth 8 years later, and look at that. We have increased quantity, quality, and density of bone, and this is supposed to be impossible to accomplish. Now, again, don't do that kind of case. That's a crazy case. Just do your 4, 5, 6s, and 7s, maybe the occasional 8. But look at what's possible. Here's another case. This is a maxillary molar with a bad bone loss on the distal root. Normally, I would do a root canal on this patient, do a hemisection and cut the posterior part of the tooth off, and then put an implant back there, and that's how we would handle it. This patient could not afford that, and there was no way they could do that. And they did not want to lose the tooth. And so we said, all right, we will try this. This tooth, I'm going to show you another 8-year post-op on this patient, and look at this. 8 years later, increased quantity, quality, and density of bone in a supposedly impossible situation. So this works. It's definitely making a huge change in how we treat periodontal patients. And we're seeing for the first time the exciting prospect of regaining lost architecture and attachment through working with our lasers. This is a traditional laser-assisted periodontal therapy. What I want you to see here is we're going to go through our 8 steps. We're going to numb them, which you've already done. You don't get to see it in this particular video, but they've been numbed. The next thing you're going to see is we're going to take the laser at 1.5 watts pulsed, and we're going to do laser bacterial reduction while we're waiting on them to get numb. And so that will be the next thing you see. You'll see the laser employed with a flashing beam, which lets you know it's pulsing on and off, and you'll see us using it around the sulcus, and we're spraying laser energy down into that sulcus to kill bacteria. Remember, taking the average periodontal pocket from the billions down to the hundreds. Takes 4 to 6 weeks for it to repopulate. So step 2 is LBR. Step 3 is going to be the scaling and root planing step. So the next thing you'll see is our Cavitron come into the picture, and we'll be using the Cavitron to remove the hard deposits. So the tartar and calculus and accretions are removed with a Cavitron and or hand instrumentation. And so that'll be done after LBR. So here is our Cavitron. So it is moving extremely fast. It has water flushing through it, and we're removing hard accretions with the Cavitron. Scaling and root planing, taking those barnacles off the pier that serves as an irritant and a reservoir of pathogens for the bacteria. Now, once we do the scaling and root planing, that was going to be step 1 was numb, step 2 was laser bacterial reduction, step 3 is scaling and root planing like you're seeing now, step 4 is going to be what we call laser curettage. Now, laser curettage is where we calibrate our fiber 1 millimeter less than the depth of the pocket, and we go in and we, remember, key word, selectively. So here we're going in and selectively targeting diseased tissue, removing it while leaving healthy tissue alone. How can we do that? Because of the differential between diseased and healthy tissue, with diseased tissue being darker than healthy tissue. Remember, the darker a tissue is, more laser energy it absorbs, and the faster it absorbs it. So we can remove the deeply pigmented tissues easy, and when we have got all that out, it'll stop cutting and we'll move on. So it's kind of like baking a cake. I'll go in 2 or 3 times, wipe the stuff off my fiber, and that 3rd or 4th time I'll go in and come out and nothing will be on my fiber. That means I removed all the tissues susceptible to that low power setting and I'm ready to move on. So that's laser curettage, and that's step 4. Step 5 is I'll do laser bacterial reduction again. Why am I doing it again? Because I did it at step 2. Because now that I've scaled and root planed and done curettage, I've opened the pocket up. And I'll get a greater depth of penetration in step 5 with laser bacterial reduction than I did in step 2. Step 6 is lavage. I'll take my Cavitron and rinse out dead bacteria and tissue tags. If I can, I'll put my medicament in my reservoir at step 6. So I'll put chlorhexidine in there. And step 7 is irrigate. 8, oral hygiene. Thank you for your attention. Thank you for listening to the information we have about the soil. It's a fantastic, exciting new product from Denmat. I hope you'll be able to check it out soon, and I hope to see you in class soon. Thanks for listening.